morning, my name is Heather Cox, and today we're going to be talking about IV initiation and IV therapy. It'll be a two-part video. The first one I'm going to talk about IV initiation. So currently we're outside the patient's room, and anytime before you enter the room, you always want to check the doctor's order to make sure that you have an order for the procedure that you're doing. You'd also want to check and see what the purpose of the IV is for, because that could determine the size of the IV, the gauge, the length. Also, the type of fluid that is ordered would determine those kinds of things as well. You also want to go back and look at the patient's chart to see if there are any contraindications for IVs in certain positions. For instance, if your patient's had a mastectomy, you wouldn't want to use the arm on the side of the mastectomy. If your patient was a dialysis patient, if they had a shunt or a graft on that side, you wouldn't want to use the arm for that as well. So you confirm the physician's orders and then the patient's history in the chart. And of course, we'll reconfirm that with the patient when we get in the room. You always want to look at the chart for the patient's allergies and make sure your patient doesn't have any allergies to tape or any of the cleaning agents. And depending on the policy, it may require that you clean with chloroprep, alcohol, or even betadine. So we're now ready to go into the room, and of course I would have wanted to have gathered my equipment before I went into the room, but I also need to assess the patient and their IV access as far as the veins and their size of the veins. So we're going to do that when we go into the room, and we'll talk about that. As I enter the room, I'm going to knock. I'm going to provide for privacy. I'm going to go ahead and foam as I enter, and then I'm going to address my patient. Good morning, Mr. Smith. How are you doing this morning? As I'm talking to Mr. Smith, I'm going to perform AIDIT, which would be to acknowledge the patient as I've done. I'm also going to ask him about his allergies. Mr. Smith, do you have any allergies, sir? He says that he does not. I'm going to introduce myself. My name is Heather. I'm going to be your nurse today, and then I'm going to go through and explain the duration and the explanation of the procedure that we're going to be doing. Mr. Smith, your doctor has ordered for us to put an IV in, and he wants us to give you some IV fluids to keep the IV open. He's also got some orders for the IV fluids to have some electrolytes and things in it because your potassium's a little bit low. And so I've explained to him the reason for the IV and those kind of things. You can also ask the patient's preference if they have a site that they prefer. Mr. Smith, do you have a preference for which arm your IV might be in? And then I need to also address any contraindications. So if he had a mastectomy, or if it was a lady, because fellas can have those as well. Also, if he had any dialysis shunts or grafts or anything like that. He tells me he does not have, he's never had any of those surgeries. He doesn't have any contraindications to that. He tells me that he would prefer to have his IV in his right arm. You might want to consider your patient's dominant arm, because sometimes they might like it in the non-dominant arm so that it doesn't interfere with movement. Another thing that could affect placement, you might not want to put it in the bend of an arm, for instance, up in the antecubital area. You might not want to put it in the wrist, which has a bend, because your catheter is a pliable plastic, and so it can get bent easily if it's in an area like this. Sometimes you don't have any choice. That might be the only vein that you can see and palpate and find appropriately. Mr. Smith, can you please tell me your name and date of birth? And as he's doing this, I'm going to look down at his armband and confirm that he indeed is Mr. Smith and that his date of birth matches. And I'm also going to check it again for the allergies. So we've acknowledged, we've introduced, we've explained the duration and the explanation of the procedure. I've confirmed any allergies, and I've confirmed my patient. And certainly before we leave the room, we'll thank the patient. So Mr. Smith, I'm going to go ahead and take a look at your arms and stuff and be kind of assessing and looking to see where the appropriate place to put the IV is at this point, okay? And he says he understands, and I'm going to step away for just a minute and make sure, of course, that he is safe and has his call bell while I'm moving around in the room. So we've talked to Mr. Smith, and we're going to go and assess his arm here in a minute for the appropriateness of the site and the placement, but some equipment and things that you might need to take into the room with you would certainly be a waterproof pad so that you can put underneath the patient's arm, because you might have some seepage of blood whenever you're putting in the IV. You'd certainly want some alcohol so that you could kind of use it to look at the site, because sometimes it helps the veins show up a little bit better. But then you'd also need whatever your appropriate cleaning agent is for your agency. Most agencies are now using the chloroprep or chloroscrub. Some agencies still use alcohol. Some agencies use betadine. So make sure you check your hospital policy so that you know what you're using. Most of your cleaning agents are going to come in one of your IV start kits. Most of your agencies have these, and in the start kit, typically you'll have the cleaning agent. You'll also have the tourniquet, which helps you apply pressure so that the veins will pop up or sit up for you so that you can see them better. They also have some gauze in there, which you can put underneath to kind of catch any blood that does leak out. And then also a securement device. But always make sure with any of your packages, we've talked about in previous videos, that you assess to see that they are clean and dry and intact and that they're within the expiration date. And check for what is exactly in them, especially latex, and make sure your patient doesn't have any allergies to any of the things that are in the kits. Other equipment that you might need would be the IV extension set or the saline lock. And this is the piece that actually connects to the hub of the IV that is into the patient. And you'd need to prepare this first because in the package originally there's nothing but air in here. So you'd want to make sure before you actually start the IV that you actually have a saline lock flush and that you've attached it and flushed it. And we'll do that here in just a little bit. You'd certainly need saline flushes because anytime you flush either a saline lock or the IV, you need to use a new saline flush, and you need to clean it with whatever the appropriate agent is in between. With any of these packages, you always check to see that they are clean, dry, and intact, and check the expiration date on any of the equipment. Some other things that you might need would be the actual IV catheters, and so I'm going to show you these here. These are consistent with some of the agencies that we currently go and do clinical at. So for instance, if you look at this one, you'll see that they're labeled by color. This one is indeed a 22 gauge and it's 1 inch long. This one is a 20 gauge and it's 1 1/4 inch long. And this one is an 18 gauge and it's 1 1/4 inch long. So whenever you're assessing your patient's veins, you want to make sure that they are wide enough in diameter to accommodate the diameter of the catheter. You also want to make sure that you have a length that is long enough for the vein that you're going to put it in that would accommodate the length of the catheter. So for the 22 gauge, its diameter is not as large as the 20 gauge or the 18. With IVs, the larger the number, the smaller the gauge of the catheter. Therefore, an 18 is certainly larger in diameter than the 22 gauge. So in IVs, the larger the number, the smaller the diameter. So as we said, the 18 is certainly larger in diameter than the 22. And then the length, like we said, you want to make sure that the vein will tolerate the diameter of the catheter because you still need to have blood flow get around the actual catheter so that, you know, it doesn't compromise the perfusion of your patient's arm. Whenever you do actually take your catheter out, the package, you definitely want to assess it for clean, dry, and intact and that the date is within. But when you take it out of the package, you want to make sure that the catheter is clean, dry, and intact and that it's not bent and doesn't have any issues with it either, and we'll come back to that. Another thing you might see would be the swab cap, and this is actually a cap that is impregnated with alcohol, and it would then go on the end of the extension set so that it actually is impregnated with alcohol and it keeps this swabbed and bathed in alcohol, so it helps prevent infections from your IVs. Some of your agencies actually have the swab cap that comes on the end of the saline flush, so make sure you're looking for that if it's there. So we've discussed some equipment that you might need to bring into the room with you before you go. Certainly I'd want to assess the vein so it would tell me the appropriateness of the IV catheter that I'm going to need. So now we're going to switch over and we're actually going to assess Mr. Smith's arm and his veins and see which ones we might use. And then we'll determine the equipment that we will go with. So now we've moved back over to Mr. Smith's arm and we're actually going to assess and look and see where the best site might be to put the IV. Again, the doctor has ordered this for IV fluid therapy, and he is going to be getting some potassium. Potassium is a little caustic to the veins, which makes them be a little bit more irritated, and you always want to keep a close eye on your IV and make sure that you don't have infiltration or any other issues, but especially anytime you have additives like potassium or anything like that that is irritating to the vein. The other thing, you know, you need to make sure if it already has a potential for irritation that you might not want to go to the areas of the bend. And so I have moved over to the IV task trainer now, and so you'll note this is what you guys will be actually doing your practice on for the most part. I'm going to go ahead and circulate the fluid through again. and make sure that it's ready. So whenever you're going to take a look at your patient's arm, it would always be good to have an actual tourniquet. And then I usually use alcohol, as long as your patient's certainly not allergic to it, to help the vein be visualized a little bit better. Now when you're looking for the site, you can pretty much tie it above the AC and kind of look down. But when you go to initiate the IV, you usually want it 3 to 4 inches above the site. So for now, I'm going to come up here and I'm going to tie the tourniquet actually all the way up above the patient's antecubital area, which is at the bend of the elbow. This is going to help engorge the veins so that I can see them. You usually don't want to leave your tourniquet tied for more than about a minute because you could potentially cause the issue with circulation to the arm. The next thing I'm going to do is I'm going to go ahead and take an alcohol swab and I'm going to put it on the vein. And I'm not cleaning it for actual insertion, so I'm just helping it illuminate the vein. Usually it helps them show and you can see them a little bit better. As I'm assessing, we already said that you want to stay away from any area where your patient decide that they'd had a mastectomy or if they had a shunt or a graft. Also, if your patient had any sores on their arm or moles, abrasions, you'd want to stay away from any of those areas, potentially the bends, assess the patient's preference. This area here at the wrist is usually a little painful, so I tend to stay away from that. Anytime you're looking, you always want to start from the patient's hand and work your way up. Lots of people don't like the IVs in the hands, and you also have to remember that it might require a smaller gauge. But it depends, like I said, again, on the purpose and your patient's wishes. So as I'm looking through here, I want to make sure that I've got a vein that's large enough to accommodate the gauge of the needle, which is the diameter, and then also the length of the needle. So if you look through here, these are pretty straight. You want to stay away from any bifurcations in the vein. If it does bifurcate, you'd want to go above it. And remember, when you start it, you always start it and it goes toward the heart, okay? So when you insert, the catheter is going toward the heart and the upper part of the arm. So I've looked at his arm and I've confirmed, and I'm probably going to go in this area in here on one of these two veins. They are straight. There's no contraindications for it. So I'm going to go ahead and let the tourniquet off because, as we said, you really don't want to leave it on for longer than a minute. At this point, now that I've confirmed the site that I'm going to go to, I'm going to get the rest of my equipment and prepare it. Alright, so we had tied the tourniquet and we had found a good site on Mr. Smith's arm so that we could actually start the IV here. If I had had issues whenever I was actually had the tourniquet tied and looking for the vein, some things that you could have him do so that the vein would pop up, and you can also do this whenever we tie it to get the IV initiated. You could have him put his arm lower than his heart. You could have him pump his fist. You could actually lightly stroke the vein, certainly before the cleaning, or if you needed to, you could put a warm, dry compress on it for about 10 to 15 minutes before you came in to do it. His vein had set up nicely for me, so there were no issues there. If your patient has a lot of hair in the area that you found, then depending on agency policy, you might clip the hair in a 2-inch area around the IV site so that it doesn't interfere with the insertion, but also with the securement device whenever you put it on the patient. So now we found the site on him, we're going to go ahead and prepare equipment. So I've already got my IV initiation kit, which I had pulled my tourniquet out. I'm going to go ahead and open it, and I'm going to take out the pieces that I will need here. And so I've already got a waterproof pad underneath my patient's arm, but this kit actually had one if I needed it. Some of the kits come with that, some of them do not. This one actually has a scrub in it. Some of them will come with a ChloraPrep swab instead, or they may have one of the little glass swabs in it that you'll actually break. You want to make sure that if it does have one of these that you don't handle this piece because it could actually contaminate it before you clean the patient. Some of the other things that may be in there would certainly be one of the Swab securement devices. Some of your actual initiation kits will have tegaderms or something else in them. They may have the gauze in there to catch the blood, and then they've got some extra tape or something like that. So I've got my pieces here in my initiation kit. Then I'm going to come back to my extension set. Again, clean, dry, and intact. The expiration date is within. When I open this up, I try to open it up to keep the inside as sterile as I can, because whenever I prepare mine, I like to put it back inside here. So when I take this out, I'm going to take it out without touching anything inside of the little plastic piece here. You're going to assess this to make sure that it's clean, dry, and intact. Whenever I come back to use it, if you are afraid that you have touched this area, then you'll want to swab it with an alcohol swab. But just to make sure you can see the difference, This piece right here is the piece that actually attaches to the hub of the catheter that's going to be inserted into the patient. And it looks like this. So this is the piece that you want to make sure that you keep sterile. And if you touch it, then you'd need to swab it with alcohol. But you definitely want to try to keep it sterile. This is the piece that hangs outside of the patient, and you would need to swab it every time before you go to flush it. So I'm going to go ahead and take an alcohol swab here, and I need to make sure that I swab it for at least 30 seconds. And we're going to say it has been 30 seconds. And once I'm done with this, then I can come back over here and I can take my actual saline flush, and I need to flush this so that it is prepared, because otherwise if I attach this piece to my patient's IV, I'm going to be flushing air into my patient, and I don't want to do that. So at this point, I'm going to take the actual saline flush out. Before you do anything with it, you either need to come to the bottom and push up on it or pull back on it. And what that does, there's a seal inside of here, so that if you didn't do that, when you took the cap off and you went to flush it, you'd have to break the seal and you'd likely squirt the patient or the ceiling. I'm going to take the cap off, and I'm now going to squirt the air out. And it comes out a lot easier like that. If you hadn't broke the seal, then you'd have issues. I have not touched this again in between the cleaning, so I'm going to go ahead and it's twist to the right. And then I'm going to go ahead and flush this. Now, whenever you flush it, if you take the cap off, you need to pull this piece back and just kind of loosen it up a little bit. And make sure when you flush it that you flush all the way to the end. Now, since I have not touched anything inside of my package and it's still sterile, then I can actually put the end right here in the package, and it's keeping that end sterile. If you feel more comfortable with putting the cap back on it, then you can certainly do that if you're worried about the sterility of the actual extension set. I like to do this because it makes it easier when I pick it up to attach it, and I'm not, having blood kind of go all over the patient. Again, you might want to bring an extra saline flush with you, because once you've used this flush and take it loose, you can't reuse it again. So I'm going to put this over here for extra if I need it. I'm going to clean up and move any of my trash out of the way, such as any of the extra pieces. And as I'm doing it, I need to make sure that I do not disturb this or contaminate it. So I've got all my equipment set up here. When I am ready, I need to come back over here and I need to retie my tourniquet. Again, you don't want to leave it on for more than a minute. And so you might want to actually tie it after you've cleaned. It's up to you, however you do. But I'm going to go ahead and tie the tourniquet now. I'm going to tie 3 to 4 inches above the site that I'm actually going to use. And I'm going to come back over here and I'm going to use my ChloraPrep. Now, when you use it, depending on your agency policy on how you need to clean, most of the time you're going to clean in a zigzag manner. And then you need to let it air dry. I would have cleaned the site for at least 30 seconds and allow it to air dry. If your patient has really fragile skin, it may say that you don't want to do a lot of vigorous scrubbing with it. It kind of depends on the patient's condition. Now, I have determined, based on the patient's vein, that I'm going to use a 20 gauge because the vein is large enough in diameter, and I do have a good 1.25 inch length of the vein. So as I'm doing this, I'm going to open it up, and I'm actually going to take the IV catheter out, and I'm going to go ahead and assess it. And I need to make sure that it is clean and dry and intact, and there are no spurs or burrs on it. I can actually touch this clear plastic piece, and I can touch the pink hub, but I cannot touch anything down through here. This needs to stay sterile. If it ends up getting touched, it's contaminated, you need to actually get a new IV. You also do not want to let the actual IV catheter go over the end, because the needle could actually pierce the catheter and cause it to break inside of your patient. When I hold my IV catheter, I actually hold it with my thumb and my middle finger, and I actually put my index finger here on this piece here, because this piece is what advances the catheter, and I like to hold back on it so that the catheter doesn't migrate down the actual needle there. Now that I have assessed this, it looks like that it is clean, dry, and intact. I need to put the lid back on it, so you need to use the one-handed capping method. And once I've got it in there, I can recap it, because I must put my gloves on before I actually do the insertion. So I'm going to come back over here, and I am going to put my gloves on. The gloves are not necessary for the cleaning, but you must have them on for the actual insertion. Once I have cleaned the site, I need to make sure that I do not touch the site again. If I do touch it, it's contaminated, and I need to clean it again. So I'm going to make sure I've got everything in position and ready for me, so that whenever I'm ready to start, I have things there and I'm not going to contaminate my site. I'm going to go ahead and take the cap back off of the needle. When you're holding, you normally want to hold with your non-dominant hand, and you want to apply traction about 1 inch to 2 inches below the actual insertion site. That keeps the vein from rolling on you, because sometimes the veins will actually roll. When you guys go to insert, you're going to insert at a 10 to 15 degree angle. So when you go in, you can actually enter on the vein or to the side of the vein. So you need to make sure you can see the vein and you're visualizing. I'm going in at a 10 to 15 degree angle, so I'm actually going to pierce the patient's skin. You would want to prepare them and let them know that you're doing this. As I'm entering, I'm going to go ahead in. And what I'm watching for is actual flash in the actual catheter. And we'll see if we get it. Sometimes on the task trainers, you may or may not get flash in the actual catheter. So when you see the flash, you would see flash or blood or return here in the actual area. Once the blood is here, you do not want to advance the needle anymore. Then you want to advance only the plastic catheter. So what I'm going to do is, with this hand, continue to stabilize the IV. And with this hand, because you use a two-hand technique, you're going to insert the catheter up to the hub. And you see how I did that. Meanwhile, this is staying still. I continue to hold this while I pull back on this until it snaps. At this point, what I have done, I have inserted the plastic catheter into the patient's vein, and I have pulled the needle back out. Please make sure that you do not pull the needle out before you have the catheter up to the hub. The needle is what needs to guide the catheter into the patient's vein. If you do not keep the needle there, then it's like shoving a piece of plastic into your patient's arm without anything to guide it there, and it's very painful, and you'll end up blowing the vein. At this point, the catheter is now there. The needle is locked because I've clicked it. I now need to come up here, and I need to let my tourniquet go without contaminating my actual extension set. At this point, I usually tell you guys to take a breath, because we're not in a hurry here. You know, you're excited, you've got the needle in and everything. What you might want to do is come and you want to get your gauze, and you can actually slip it right underneath here without touching your site up here. And when you do this, we're going to take this piece apart and now attach the extension set. So without touching my site, I'm going to come, and I have now stabilized the hub, which is the colored piece. I'm going to take this apart, and you may or may not see blood return at this point. You need to make sure and attach this. And once it is attached, you will see I never let go of my actual catheter here while I'm doing my IV insertion. I'm also going to make sure I keep my sharp in view. Once I'm ready, I'm now going to flush this. And as I flush, I actually look to see if I've got swelling or if the patient complains of any pain up here at the site. If you have swelling, then you probably do not have a patent IV. You can pull back, and you'll be looking for what we call flash or blood return here in your actual extension set, and then you can continue flushing. And as long as it flushes without difficulty, and you don't have any swelling or issues up here at the site, you can now come and you can take your gauze out. Without touching the site, you can again make sure this is attached correctly. Then you're going to come up here and you're going to put your securement device on. And so you notice I never let go here of this because it could end up coming dislodged. So as I pull this thing off of here, basically what I'm going to do, I usually peel the bottom first. And you want to make sure that you are aware of your agency's policy for how you secure this down, but you do not want to be touching the site up here as you're doing it. So once I put the Swab view down here, typically the way you need to have it is so that you can actually see the color of the hub of the catheter and that you can see the insertion site in the insertion window. Then there may very well be a secondary piece which comes down underneath the actual tubing, and you can peel one side and secure it down, and you can peel another side and secure it down. All right, so we had put the securement device down, and as we said, you want to make sure that you can see the actual insertion site through the window, and you want to be able to see the colored hub so you can tell what gauge it is. Now, once I've got this on here, then I can come back over here because I want to clamp this. You want to always keep your saline lock clamped because you could potentially have blood return down through here. So what you want to make sure and do is, as I'm flushing, and it's kind of hard, you got to have like 3 hands, as I'm flushing, I want to go ahead and clamp the clamp. And what that does is it keeps the blood from returning down. Now I can actually go and take the saline flush off. Once I have taken this off, I cannot reuse it. You need to remember that. It takes a new flush for every time. Then I can come back down and I can take another one of the little securement devices, and I can come and I can secure this. And you'll see different ways for how this is done. You may see that they'll secure it down the arm and tape it. You may see that they'll kind of do it in a loop and put it up here. And at this point would be when you would come and you would take the swab cap and open this up, and don't touch this here. Come into this piece here, and it actually just pushes directly on here. And the swab cap will sit here on the end of the actual saline lock, and it's impregnated with the alcohol, and thus it helps prevent infections. Whenever you come back in to use this, then you would need a fresh saline flush, and if you have the swab cap on it, you do not have to swab in between. If the swab cap is not on it, then you must take a fresh alcohol swab and swab before you put the saline flush on. Now, in some agencies, before you put on the actual securement device, they may have some type of skin protectant that you might put on underneath the skin. But always remember, until you get this covered, you do not want to be touching the site in here because you could contaminate the site and cause your patient infection. At this point, you would now want to come back over to the securement device. Some of the packaging that comes with it, there's some stickers on here, and you'd want to come and you'd want to put the date, time, the initials, and the gauge of the IV on here, and you'd want to peel this off after you've written it, and you'd want to put it off to the side. You never want to put it over the top of the window of the securement device because you cannot see your actual insertion site. So I would have date, time, initial, and gauged it. You always want to come back through and reassess your site and make sure your patient's not having any pain here. You want to make sure that there's no swelling or redness. When you do your assessments of your IV, if there is swelling, then that could be a sign of infiltration. You're not going to see what we call phlebitis immediately. That takes a little bit of time for it to develop, but typically what you would see would be like a little red streak or the swollen part up above the actual IV insertion site, and that would indicate phlebitis. Either of those things would indicate issues with the IV. Certainly anytime you come in and assess the IV, you should always be flushing it, because the only way you can state that your IV is patent is by actually flushing it and making sure that you have blood return, that it flushes well, and that there's no swelling or irritation at the site. So we've discussed how to come in and how to assess your patient's veins, and how to go through and find an appropriate site, and how to actually do insertion, and how to assess a site. And as we said, anytime before you use the saline lock, you always want to make sure that you flush it and assess for patency. Now that we've got it all secured and it's labeled, then what I'd want to do is come back and gather my equipment. All of these things can go in the trash except for your actual sharps, which should go in your sharps box. If your saline flush has had any blood exposure in it, then you might need to put that in the actual sharps box. The rest of the stuff can pretty much go into the trash. I would want to go ahead and take off my gloves at this point once I'm disposed of everything. I want to go ahead and foam. And after I've foamed, I'd want to make sure and go ahead and speak to Mr. Smith and ask him if he's having any issues. If I had raised the bed to start the IV, I'd want to make sure and lower it. I'd want to make sure his bed is locked and low and that he has his call bell, and ask if he is comfortable the way he's laying. So I want to address the 4 Ps, and we'd want to make sure he's not having any pain at his IV site or anywhere else. I want to make sure he's in a good position. Does he need me to raise or lower him? I need to see if he needs to go potty. He said that he's not, and I want to make sure all his stuff is in proximity. So he has his call bell. Certainly I'm going to clean up the table if I have not already done that and get everything out the way. If I have actual IV catheters and extra equipment at the bedside, I need to make sure and take that out of there. You never want to leave needles or any of that kind of stuff at the bedside. I need to make sure, again, his bed is low and that it's locked. And that he is in a safe position. I need to make sure he doesn't need anything else, and then I need to thank him for allowing me to care for him that day. I would also want to come back in about 30 minutes and reassess the IV site and make sure that he's not having any issues with it, any increased pain. If you have a confused patient, you may want to assess the IV site more frequently. Always make sure that you assess it at a minimum for whatever your policy says at the hospital, and most of them are at least once a shift or every 4 hours. When you're in clinical, typically we have you do safety checks every 2 hours, and you should be assessing your IV at every point when you do your safety checks. Also, for patency, you need to flush the IV at least once a shift or whatever your hospital policy says to make sure that it is patent. But again, if I came back in and I needed to start IV fluids on him, I would need to make sure to flush it and make sure that everything is what it needs to be and that it is patent. Thank you very much, and I will be doing IV therapy in the next video.